So these are the non-depolarizing neuromuscular junction blockers or antagonists. The prototype here is D-tubercurarine, atracurium, pancuronium, rocuronium. These are the drugs that are used for a variety of different procedures. They've got a different kinetic profile. You can kind of categorize them whether or not they're short-acting versus long-acting. The short-acting ones are typically used for intubations. The intermediate to longer acting ones are used for more kind of involved surgeries. These drugs are also kind of part of the capital punishment type of procedures or euthanasia type procedures where patients are basically put to sleep. They're also used in veterinary medicine to assist animals putting to sleep. They've got an interesting history. They were first kind of discovered looking at the natives from South America and how they hunt some of their animals. Some of these poisons can be collected from the backs of these poison dart frogs, and then others are extracted from this plant, which is curare, and this is the kind of the prototype chemical. The chemicals from the frogs are very similar. The frog has the ability to make this compound based on the insects that are probably associated with this plant. There's at least probably some type of food chain crossover. But a lot of the curare is isolated from these South American tropical type vining plants. And they have what's called surmountable affinity. And so it's a competitive affinity at this receptor, meaning that high doses of acetylcholine can kind of outcompete these antagonists at the receptor's location. And you can also kind of get a favorable outcome by looking at acetylcholinesterase inhibition. And so either one of those ideas will have the ability to produce more acetylcholine to kind of compete this curare type molecule away from the receptor. Okay, and so because they're competitive antagonists, the only thing we really have to do is worry about assisted breathing. But we can supply acetylcholinesterase inhibitors, which again would be kind of indirect acting agonists at these receptors, producing more acetylcholine. Pyridostigmine would be a good drug of choice here. So if you block the degradation of acetylcholine, you can increase the amount of acetylcholine and then compete the drug for the receptor. Okay, and so here we see at the receptor site, we can see competition for the receptor between acetylcholine and these curare type molecules. And when these curare molecules are bound, there's affinity without efficacy, so they are true antagonists. But what's good about them is that they're competitive, and so they can be slightly reversed. Okay, or I'm sorry, quickly reversed. There's a dose-dependent effect where you see kind of weakness and paralysis, and so the clinical outcome is the same. The only difference is really based on the biophysics at the receptor type, at the receptor site. And so whether they're depolarizing versus non-depolarizing, that refers to the biophysics within the receptors spot itself. The clinical outcome is the same. We're looking at using these drugs for surgery. We're looking at using them for really global muscle paralysis for intubations. They don't really cross the blood-brain barrier because they've got poor lipid solubility. We'll talk more in detail about the blood-brain barrier in the next module. But they have a profound effect on respiratory muscle activity. And so if the patient is exposed or is administered any of these drugs and they're not properly ventilated, they most likely will die from respiratory distress. And so, again, just in terms of the toxicity, really high doses or unintentional doses or exposures can produce respiratory depression. The patient's going to need ventilation until the drug can be reversed. And we talked about reversal processes previously. We also see a release of histamine, particularly with D-tubercurarine, producing a hypotensive crisis, if not given something like Benadryl or an antihistamine. And we see lots of drug interactions with other drugs to kind of prolong this muscle weakness. I do want to draw your attention to the literature. Here's a nice comparison table from one of the pharmacology textbooks looking at the effects of D-tuberocurarine compared to the effects of decamethonium. And of course, we're looking at the difference between a competitive or non-depolarizing neuromuscular junction blocker with a competitive, non-competitive or depolarizing neuromuscular junction blocker. And so I just wanted to say that there's more jargon, unfortunately. Depolarizing means non-competitive, non-depolarizing means competitive. Okay, and these are the prototypes of each one. Okay, I do understand that in terms of the agents like decamethonium, which are the depolarizing drugs, there is no reversal. The drugs that are competitive non-depolarizing neuromuscular junction blockers have the ability to be reversed with high doses of acetylcholine or acetylcholinesterases. Okay, so that's going to be the end of this lecture segment right here. In your notes, we've got a couple of tables just kind of summarizing the different effects on some of these neuromuscular junction blockers. You don't need to know all this in terms of the time of onset and the clinical duration of activity. This is just kind of background information. I think these tables are interesting, but I'm not going to test you on them, and you can see there's no learning objective associated with that. Okay. Let's end right here, and we'll finish off with just a couple of environmental type correlates and a quick kind of summary session.